Next is papillary thyroid cancer. It's V7. 38-year-old woman has been referred to you with a 30 millimeter papillary thyroid cancer with a confirmed THY-FNA pathology. How would you manage this patient in the clinic? So first of all, I would take the history of previous irradiation, family history of endocrine disease, examine the patient looking for symptoms and signs of local invasion or distant mets, horse voice dysphagia, arrange an ultrasound scan of the neck above for the gland consistency and the lymph nodes, and patient might need FNAC. Then request serum thyroid function test, calcium levels and vitamin D levels. What are the risk factors for developing papillary thyroid cancer? Environmental living in iodine-rich areas, exposure to the ionizing radiation, for example, Chernobyl or direct radiation of the neck. Radiation is thyroid tumors that are papillary 5% familiar. What are the pathogenesis features of the cancer? Pathological features: it's macroscopically hard whitish nodule, microscopically it's orphan any cells and small bodies. Also follicular encapsulated, diffuse squeezing and tonsil variant, early lymphatic spread, late immunogenicity threat. What are the key surgical steps involved? If tumor is less than 4 cm, I would do hemithyroid lobectomy. However, if there was any prospective evidence of lymph node involvement on the ultrasound scan, then a total thyroidectomy with central 6 and 7 lymph node modified radical lateral neck dissection should be performed depending on the extent of the involvement. The thymus is usually spared. The thymus ideally is not repaired. Avoid devascularizing inferior parathyroid. There is less than around 2. What are the key surgical steps? If tumor is less than 4 cm, thyroid lobectomy can be performed. However, there is any preoperative evidence of lymph node involvement on ultrasound, then a total thyroidectomy with a central lymph node 6 plus 7 plus modified radical neck dissection performed. Thymus ID is not removed. Avoid devascularizing inferior parathyroid. There is 3% incidence of permanent postoperative hypoparathyroidism. How would you follow up the patient? In the immediate post-op period, determine serum calcium and parathyroid hormone. Should undergo total thyroidectomy. Start levothyroxine 2 microgram per kg. Results should be discussed at an thyroid MDT and a decision made about whether the further treatment is required depending on the pathological features. Further surgery if only lobectomy from radioactive iodine. Levothyroxine replacement aims to suppress the patient TSH level to prevent the regrowth of the thyroid tissue. Therefore, the patient requires regular thyroid hormones test initially 3 months and then move to the yearly follow-up. Thyroglobulin levels and thyroglobulin antibodies could be checked annually in the clinic. Follow-up ultrasound is indicated at 1 year and then subsequently thyroglobulin levels begin to rise. So the patient is concerned about needing radioactive iodine treatment and being radioactive around her children. How would you explain the treatment to her? Prior to receiving radioactive iodine should be started iodine diet. Radioactive iodine, she will need to have a low iodine diet for 2 weeks. It also likely be commenced on recommended TSH on local policy. The radio iodine is given as a capsule and patient will kept in isolation in hospital for 48 hours. Once her radioactive levels are acceptable, she will be allowed to go home. In the immediate post-treatment period, she should remain well hydrated and flush the toilet while boarding. On leaving the hospital, public transport may be taken for journeys less than 3 hours. And children age more than 1 may vary more than 1 millimeter away from 9 to 15 days depending on the dose. Only 15 millimeter of close contact is allowed for the first 24 days, and after radioactive iodine she can share a bed with her partner. However, at high dose treatment requires spare the bed for 4 days. All utensils must be rinsed thoroughly. Clothing does not need to be separated. The sole caregiver of the children, the arrangements for care may be made for 25 days. What is her prognosis? The prognosis of papillary thyroid cancer is generally good. There is more than 90% survival at 20 years. Using the masses calculator, METS, age, completeness of excision and dissection margins, and section masses. Other scoring system used are the ages and MS. Thank you.